Hello and welcome to the next Saviours Essential Question Series for NEET PG 2025. Today we are going to have a discussion on the identification and management of a very important condition, that is neonatal respiratory distress syndrome. So starting obviously with the question first, that a 30-week gestation preterm neonate is delivered by a spontaneous vaginal delivery after prolonged premature rupture of the membranes. At birth, the infant has the Apgar score of 5 at 1 minute and 7 at 5 minutes. The moment you recognize these two important components to be provided to you in the question, like a prematurity, that is preterm, and a low Apgar score. Now, all of you know the Apgar score is a rapid method used to assess the newborn overall physical condition immediately after the birth. And the components of the Apgar score are skin appearance, the pulse, the grimace, the activity, and the respiration. Now, based on that, each of the five component is assigned a score from 0 to 2 with a total maximum score of 10. Like in case of skin, if the entire body is blue or pale, the score 0 is given. The entire body is pink, but the extremities are blue, the score 1 is given. And the entire body is pink, then the score 2 is given. Similarly, in case of heart rate, if there is no heart rate, then score 0. If the heart rate is less than 100, score is 1. And if the heart rate is more than 100, score is 2. In case of reflex irritability, if there is no response to stimulation, score 0. If there is a grimace or feeble response when stimulated, score 1. While if there is a vigorous cry or pull away when stimulated, then it is score 2. Similarly, for the muscle tone activity, if there is no movement, then 0 score. Some flexion of the arms and legs, score 1. And active movement, good muscle tone, score 2. If the breathing efforts are counted, then no breathing, score 0. Then slow, irregular breathing, score 1. And good, strong cry with a regular pattern of the breathing is score 2. So, interpretation of the Apgar score is like if the score comes in between 7 to 10, thus it means that it is normal, the newborn is in good condition. If the score is in between 4 to 6, now there is a problem which indicates moderate distress. But if the score is in between 0 to 3, then it is reflective of the severe distress and immediate resuscitative measures are necessary. So all of you are aware of the Apgar score. If you go back to the question, when you have identified a prematurity or a preterm delivery with a low Apgar score, then you have started thinking in the direction of the hyaline membrane disease. That means respiratory distress syndrome of prematurity. Now, all you have to do is now to consolidate your answer. Now, within the first few hours, the neonate develops marked respiratory distress characterized by tachypnea, grunting, nasal flaring, and visible intercostal retractions. His oxygen saturation on the room air is around 80%, and the chest radiograph reveal a diffuse reticulogranular appearance with air bronchograms. Now, all of us are aware of the fact that the characteristic findings in case of respiratory distress syndrome is the preterm infant. As far as the timing is concerned, then it typically presents within the first 2 to 6 hours after the birth with a characteristic clinical signs in the form of tachypnea. Grunting is actually a compensatory mechanism to maintain an expiratory pressure. Nasal flaring and retractions, which reflects increased work of breathing, and ultimately the cyanosis. So, in moderate to severe cases, because of the impaired oxygenation, there could be a cyanosis also, with a laboratory finding of hypoxemia and respiratory acidosis. As far as chest findings of respiratory distress syndrome are concerned, it shows a typical ground glass appearance or a reticulogranular appearance, air bronchograms, and decreased lung volumes due to widespread atelectasis. By this time, you already have recognized that the patient is suffering from the respiratory distress syndrome of prematurity, but it is also important to differentiate it from the other causes like neonatal pneumonia and meconium aspiration syndrome. You see, neonatal pneumonia, because it is a systemic infection, so there has to be a feature of respiratory distress along with the signs of systemic infection. Like there will be raised temperature, lethargy, poor feeding, and apnea provided to you in the question. Another very important point which would be provided is the risk with the maternal infection, like in the form of chorioamnionitis. On the other hand, for meconium aspiration syndrome, it typically occurs in term and post term infants, often associated with the fetal distress. and it appears immediately after birth with immediate respiratory compromise. As you know, on X-rays, there will be a patchy, heterogeneous infiltrates with the areas of hyperinflection and atelectasis with the risk of air leaks, but it will be presented to you with the severe respiratory distress, gasping, irregular breathing, possible asymmetric breath sound, and may have signs of persistent pulmonary hypertension. So this is how you have to distinguish it in between the neonatal pneumonia and meconium aspiration syndrome. So, by looking at the question now, you have already identified that we are talking about the question of the respiratory distress syndrome of prematurity. And now we have to continue reading the question that neonate is promptly started on continuous positive airway pressure with FiO2 of 40% to support his breathing. However, despite CPAP support, his oxygen saturation only modestly improves to 88 to 90%, and he continues to exhibit significant work of breathing. What is the most appropriate next step in the management of neonate? So once you have identified it to be a feature of RDS, respiratory distress syndrome, now the treatment follows a systematic stepwise approach. So obviously the first step is the immediate stabilization at birth by preventing the hypothermia, suctioning meconium if at all is required, tactile stimulations, and positive pressure ventilation if required. Now, coming on to the step two, that initiate the respiratory support. You know, the first line therapy is obviously the continuous positive airway pressure. Now, when it has to be given, if the infant is spontaneously breathing but shows the signs of distress, why it has to be given? Because CPAP prevents alveolar collapse and improves oxygenation. Then, how it has to be given? You see, start CPAP with the FiO2 of 30 to 40% and adjust based on the SpO2 levels. Ultimately, the target oxygen saturation is to achieve in between 90 and 95%. If it is achieved, continue with the CPAP and wean if at all required. But if the SpO2 remains less than 90% despite FiO2 of more than or equal to 40%, or even if the SpO2 comes out to be in between 90 to 50%, but the signs of severe respiratory distress like grunting, retractions, high respiratory rate are still persistent, then in that case you have to proceed to the step 3, that is surfactant therapy. You know, administration of the surfactant, what are the indications? As we have just talked about, that persistent respiratory distress despite CPAP, FiO2 of more than 40% required to maintain the SpO2 of more than 90%, and moderate to severe features of RDS on the X-rays. Then how is it provided? You see, through the endotracheal tube in intubated neonates. In case the patient is not yet intubated, then you have to temporarily intubate it in order to provide it. And what is the role of it? It improves oxygenation, it reduces the need for the mechanical ventilation. Now, once the surfactant therapy has been given, if the infant improves, then attempt extubation to CPAP again. If there is no improvement, then in that case, you have to proceed to the mechanical ventilation. Now, you know, mechanical ventilation indications, as we have just talked about, that there is a severe respiratory failure despite surfactant is being provided. pH remains less than 7.2. Partial pressure of the carbon dioxide becomes more than 60 millimeters of Hg. That means the patient is landing up in respiratory acidosis, and FiO2 of more than 60% needed to maintain the oxygenation. Then in that case, mechanical ventilation has to be given by a conventional mechanical ventilation or with a high frequency oscillatory ventilation in case of severe lung disease. Now, what is the target? The target obviously is to maintain the SpO2 in between 90 to 95%. Why not 100%? To prevent oxygen toxicity like retinopathy of prematurity. These are needed to be prevented. If you go back to the question, then despite CPAP support, his oxygen saturation only modestly improves to 88 to 90%, and he continues to exhibit significant work of breathing. So, what is the most appropriate next step in the management of this patient? If you read this option by option, then the first option is that increase the FiO2 on CPAP to 100% and continue monitoring. Then simply increasing the FiO2 will provide more oxygen but will not address the underlying surfactant deficiency. As you already know, that prolonged high oxygen concentration, like even if we give FiO2 of more than 60%, it increases the risk of oxygen toxicity and the complications such as bronchopulmonary dysplasia. So, since the neonate over here is still in the respiratory distress, escalating the support like intubation along with the surfactant is necessary, and that is why the option B seems to be the correct answer. Why? Because this neonate, he remains hypoxic and has a significant work of breathing despite CPAP with FiO2 of 40%, indicating a non-invasive support alone is insufficient. So the next best step is intubation and exogenous surfactant therapy. But before marking the correct answer, let's see other options too. Like option number C is transition to conventional mechanical ventilation without surfactant. Mechanical ventilation alone does not address the primary cause of the respiratory distress syndrome. Without surfactant therapy, obviously, the neonate remains at the risk of alveolar collapse, worsening gas exchange, and prolonged ventilation dependence. So, surfactant administration significantly reduces the severity and duration of respiratory distress. So, this option is also incorrect. And finally, switch to the oxygen hood and observe for further improvement. Oxygen hood, obviously, as you know, it is not sufficient for managing the moderate to severe respiratory distress. It does not provide the positive pressure support, so that it cannot prevent the alveolar collapse in unit with surfactant deficiency. So this option is also incorrect. So as you know that the intubation and exogenous surfactant therapy is the best answer for this question. Why? Because surfactant therapy helps restore the alveolar function, reduces surface tension, and improves the gas exchange. So hopefully you have understood that first how to identify the question is related to the respiratory distress syndrome of prematurity. Second, what is the step-by-step management protocol for these type of the questions? And third is there any protocol for the prevention of the respiratory distress syndrome? Yes, antenatal corticosteroids like betamethasone, dexamethasone are to be given when to the mothers who are at the risk of preterm delivery. And why it has to be provided? Because it accelerates fetal lung maturity and reduces the RDS risk. Another way is by delaying the cord clamping, which improves neonatal circulation and decreases the risk of respiratory distress syndrome. So, thank you very much. All the best for your future examination. Hope the session was helpful. In order not to miss any update, please join our Telegram group. The link is provided in the description.